This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the 2026 edition of the journal Clinical Neurology and Neurosurgery. The paper is titled Combined Middle Meningeal Artery Embolization and Subdural Evacuation Port System Drainage for Chronic Subdural Hematoma, a systematic review, single-arm meta-analysis, meta-regression, and cost-benefit analysis.
This is a timely discussion, Ilara. For those of us in the OR every week, chronic subdural hematoma, or cSDH, is becoming an increasingly prevalent part of our practice. We are seeing more older patients, many of whom are heavily anticoagulated and medically frail. While the standard burr hole evacuation has been our bread and butter for decades, the recurrence rates and perioperative risks in this specific demographic remain a significant hurdle.
Exactly, Dr. Aris. And I think what's most interesting about this study is how it reframes our understanding of the pathology itself. We used to look at cSDH as a simple mechanical problem, a fluid collection that needs draining. But this paper emphasizes the growing recognition of cSDH as an angiogenic and inflammatory disorder. It's a biological process, not just a static volume of blood.
Right. It's that fragile, leaky membrane that keeps the cycle going. That's why the study focuses on a combined strategy, MMAE-SEPS. That stands for Middle Meningeal Artery Embolization, combined with a subdural evacuation port system. It's essentially a two-pronged attack, targeted modulation of the underlying vascular pathology paired with mechanical decompression.
It's a clever synergy. The authors conducted a systematic review and a single-arm meta-analysis to evaluate the safety, effectiveness, and the health economic profile of this combined approach. For the residents listening, the SEPS component is a minimally invasive drainage system that can often be done at the bedside under local anesthesia, which is a major advantage for those frail patients Dr. Aris mentioned.
And then you add the MMAE. By embolizing the middle meningeal artery, you're essentially cutting off the fuel to those friable neovessels in the subdural membrane. The paper compares this combined approach to our conventional burr hole evacuation. Ilara, what did the meta-regression and analysis show regarding the effectiveness?
The study aimed to see if this dual approach could bridge the gap where standard surgery fails. By using MMAE to address the angiogenic and inflammatory nature of the hematoma, the data suggests a significant reduction in recurrence compared to historical cohorts of burr hole surgery alone. The meta-analysis really highlights that by combining mechanical decompression with vascular modulation, we aren't just treating the symptom, the mass effect, but we're treating the source of the rebleeding.
And let's talk about the health economic profile mentioned in the title. That's a term we're seeing more often in neurosurgical literature. In a population that is increasingly older and medically complex, a standard surgery often leads to long hospital stays or readmissions due to recurrence. If a combined MMAE-SEPS approach can be done with lower perioperative risk and a lower rate of return to the OR, the cost-benefit ratio starts to look very favorable for the hospital system.
Precisely. The study suggests that while the initial cost of the embolization materials and the port system might be higher than a simple burr hole kit, the overall savings come from reducing those substantial perioperative risks and the high cost of managing recurrences. It's about the total episode of care.
It's also about the minimally invasive aspect. For a medical student or a junior resident, the takeaway here is that we are moving toward a more nuanced biological surgery. We aren't just plumbing. We are looking at the inflammatory markers and the vascular supply. The SEPS provides that immediate relief of pressure, while the MMAE ensures that the relief is permanent.
And the study was quite rigorous in its methodology, using meta-regression to account for different variables across the studies they reviewed. It really reinforces the idea that for the anticoagulated patient, this could become the new gold standard.
It's a compelling argument. We are shifting from one-size-fits-all burr holes to a more tailored approach that respects the frailty of our patients. If we can achieve the same or better results with a bedside port and an endovascular procedure, it changes the entire workflow of a neurosurgical service.
It certainly does. This paper is a must-read for anyone looking to modernize their management protocol for cSDH.
Well, that's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Ilara. We'll see you in the next episode.